welcome to the inaugural Preciska Virtual Breast Cancer Tumor Board. So happy and honored to have our August panel here. I'll introduce them one by one. In fact, they will introduce themselves. First, Dr. Tari King from Harvard.
Thank you. Hi, I'm Terry King. I am the chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Center. I enjoy taking care of breast cancer patients and particularly the multidisciplinary approach that we're able to take, and I'm happy to discuss these cases with you today.
Hi, my name is Tom Buckles. I'm the medical director of Scripps MD Anderson Cancer Center in San Diego. I have been at MD Anderson in Houston as a radiation oncologist for 20 years, and I specialized in breast cancer. I love to participate with my multidisciplinary colleagues in the management and research of breast cancer.
Hi, I'm Dr. Bill Gradisher, professor of medicine and chief of hematology oncology at Northwestern University, where I've been for the last 30 years. And I also, along with my colleagues, enjoy taking care of breast cancer patients and the challenges that come with understanding the nuances with each and every case.
Hi, I'm Rennie Butler. I'm Associate Professor of Diagnostic Radiology at Yale University School of Medicine and on the medical faculty of Yale New Haven Hospital and Smilow Cancer Hospital. Looking forward to participating in this panel. I really appreciate the multidisciplinary perspective, and I look forward to presenting the imaging findings, which are really a rapidly evolving technology. And so we'll be discussing how that technology can hopefully be more and more helpful as time goes on.
So Dr. Gradisher, you have this case of a 37-year-old premenopausal female who presented with a large right breast mass. Tell us about that.
Sure. So this was a 37-year-old premenopausal woman who presented with a large right breast mass that had rapidly enlarged over the prior 2 months. She had been getting annual mammograms, which had been normal. On her physical exam, her right breast had about a 5-centimeter mass. It remained freely movable. There were no obvious skin changes. However, there was some slight nipple inversion that she had noted and could be detected on exam. There was no appreciable axillary adenopathy. She underwent a biopsy that showed a hormone receptor positive but PR poor and HER2 negative, HER2 3+ tumor. Ki67 or proliferation was quite high at 40%. She had an axillary ultrasound, which was negative, and she subsequently received TCHP, which is chemotherapy with 2 anti-HER2 directed therapies, and had a clinical complete response. And her MRI of the breast prior to surgery showed no residual disease. And at the time of surgery, because the response had been so good in a larger breasted woman, she actually ended up having a lumpectomy and was found to have a pCR, and there was no lymphadenopathy on the sentinel node. I'm sorry, there was no positive nodes on the sentinel node biopsy. She was started on tamoxifen, and she completed the planned course of post-surgical anti-HER2 therapy, which consisted of trastuzumab and pertuzumab.
So, Dr. King, you have seen cases like this. What would you have done if she had come prior to seeing the medical oncologist, which many of these women do even now, and enlightens us the approach that is taken typically at your institution?
Thank you. So yes, we do see these women who present with large breast masses. She is obviously too young to be undergoing mammographic screening, and so thankfully she was aware of this change in her breast. It's important, if the surgeon is the first physician to see these young women, it is important to discuss the tumor biology and the importance of the tumor biology in making treatment recommendations. And so we would also have highlighted for her the HER2 positive nature of her disease, that this makes her a candidate for chemotherapy with anti-HER2 therapy. And when we know that patients will receive this form of therapy, we consider again, is there an advantage to giving it in the upfront setting or before surgery? So I explained to her that this this treatment is indicated, she will receive it one way or the other, or the recommendation will be for her to receive it one way or the other. And so from a surgical point of view, there are many advantages to her getting it preoperatively. As Dr. Bradishar mentioned, that she had an excellent clinical response. She was able to undergo a lumpectomy and her lymph nodes were clear. And so that the preoperative therapy really then allowed us to optimize her local therapy.
So Dr. Butler, I know you have a separate video on MRI of the breast. Give us some thoughts about MRI in this case, or MRI of the breast in general, where you use it in these women.
Sure, thank you. The most common indication for MRI of the breast is to screen women at high risk, such as women with known BRCA1 or 2 mutations and other genetic predispositions, or a strong family history that results in a calculated risk of greater than 20%. Another indication for breast MRI that is a little bit more controversial is when to perform breast MRI for women who have a new diagnosis of breast cancer to search for extent of disease. In this case, the fact that she has a triple negative breast cancer would be an indication, or a highly aggressive, biologically aggressive breast cancer would be a potential indication for breast MRI. Similarly, in women with invasive lobular carcinoma, we know that those cases are more often bilateral and more often underestimated in terms of their final size on the basis of the mammogram and ultrasound, and that MRI can show us additional sites as well as additional bilateral, contralateral involvement that was unsuspected. One of the interesting things about these kinds of cancers is that the most biologically aggressive cancers are ironically deceivingly benign in many cases on imaging, so that they don't have the classic appearance of a spiculated mass that represents a red flag for us to know that it's malignant. They can often appear almost circumscribed, like benign masses. And so not only are they missed more often because they grow so rapidly that they might represent an integral cancer, even in women who are being screened, but they're also sometimes missed because they're misinterpreted as a benign mass. And the way to avoid that is really just to pay very close attention to detail when we do imaging, and be very careful about whether or not the margins are truly circumscribed. They may be nearly circumscribed, but often they do have some telltale irregularities. And then other technologies are being developed to try to overcome that limitation. We are about to trial AI, or artificial intelligence, in the breast using breast ultrasound to see if some of these deceivingly benign appearing cancers might be flagged by artificial intelligence and help us to recognize them.
That's fascinating. So Dr. Buchholz, I know after lumpectomy, you do radiation therapy after breast preservation. Please comment on that, but also comment on whether this woman, theoretically, if she underwent a mastectomy, would there be a discussion about radiation after mastectomy due to the tumor size or not?
Well, thank you. I think it's very important for people who are going to be treated with neoadjuvant chemotherapy that they really have an accurate depiction of the extent of disease before systemic treatment is given. Here it looks as if I would probably stage her if her disease is not greater than 5 centimeters as a T2N0 or clinical stage 2, but clinical T2N0. I'm glad that her axilla was looked at with ultrasound in addition to physical examination and found to be negative. So that's great news. That's an early stage cancer and had an excellent pathologic complete response. So clearly, as you mentioned, radiation to the breast would continue to be a very important component. I would not feel inclined to do any additional radiation to regional lymph nodes. And if she were treated with a mastectomy, I would not be inclined to do post-mastectomy radiation. I kind of equate post-mastectomy radiation and regional lymph node radiation in kind of the same decision-making process. Whenever I do post-mastectomy radiation, it includes regional lymph nodes. And so it's consistent with decisions if if you're treating with breast conservation, sometimes we add that regional lymph nodes with separate fields in addition. And in this case, I wouldn't feel it's necessary because she was lymph node negative clinically and pathologically lymph node negative at the back end.
Great. So let's move on to the follow-up patient. Dr. Butler, do you want to comment on it?
Sure. Here we have view of the knee, and along the lateral aspect of the femur, we see a lytic lesion, which we can appreciate as a darker area. Some of the bone has been sort of eaten away here. It's slightly expansile. We see that the margin of the bone here is not well preserved. And so this is suspicious for a possible metastasis to the bone.
Great. So Dr. Gradishar, when you saw that, you did a biopsy, of course, and some people would say, isn't it quite obvious? Why did you biopsy? What do you say to those people?
Well, I think in the setting where you have a new lesion that shows up, you want to make sure that, one, the markers are consistent. And by that, I mean compared to the original diagnosis. So there may be, occasions where you're surprised where the diagnosis is completely different. Could this be a bone tumor in the absence of any other metastatic disease? Because it's a little bit strange. It's not common when recurrent disease develops, particularly with breast cancer and bone. It's not that common to have an isolated single lesion. So it would be important to confirm the diagnosis, but equally important to know that the markers remain concordant, the same as the original diagnosis. And here, what has changed is where she had been HER2 positive, she is now reported as HER2 negative.
So is it because, would you postulate that it's due to tumor heterogeneity or different populations of cells in the tumor, and HER2 positive cells got killed by anti-HER2 therapy, and what was remaining was just ER positive or hormone receptor positive, and that often goes to bone? Would that be your lead theory, or
that would be a good theory? Whether that explains it, whether it's heterogeneity, whether it was a dominant clone that remains, which this pattern is consistent, ER positive disease to the bone. And what's atypical, as I said earlier, is just a single lesion. But the other possibility as well is whether, there's any technical issues with staining or doing the HER2 testing on bone as opposed to, some other soft tissue site. So there's a variety of
problems with staining the bone. What are the pitfalls of obtaining tissue from bone?
Well, the decalcification process might lead to some false results, not truly representative of what's going on. So I think all of those possibilities that you cited have to be taken into account. But what we're dealing with at the end of the day appears to be oligometastatic disease roughly 2 years after her diagnosis.
And by oligo, you mean very few sites, one or two of
in this case, a single lesion.
Yes.
So I also think it would be important, and Dr. Gradishar, I'm sure that you had this on this patient, but important to point out for everyone that you want to make sure that her breast screening has been up to date and that she possibly doesn't have a new contralateral breast primary with this different profile. She was a young woman and had a complete pathologic response to her pre-op therapy. So this disease recurrence in such a short interval certainly wouldn't be expected. So we just want to make sure that there's not a new breast primary that could account for this.
Correct.
Yeah, that's an excellent point. Or again, going along the previous hypothesis, it would probably could be that she had already seeded the ER positive portion of the disease into this bone when she had her preoperative therapy and surgery. So these are some considerations that we can discuss. Was original endocrine therapy optimal? Again, Dr. Gradishar, you're the expert in systemic therapy. What would be your reply to that?
So I think the issue there is this was a younger woman who got tamoxifen alone, and the case could have been made for, in addition to tamoxifen, doing ovarian suppression to really optimize, eliminating or driving down her hormone levels. That was discussed with the patient, but the patient was a little bit concerned about the onset of abrupt postmenopausal symptoms. So that would be one consideration. Obviously, if she was made postmenopausal, the secondary concern or consideration would be, could you use an aromatase inhibitor instead of tamoxifen to further optimize endocrine therapy? So that's neither here nor there because she didn't get either one. But I think the question now becomes, with oligometastatic disease, what the approach should be with respect to local therapy as well as systemic therapy.
So what would you do? I know you have raised the possibility of radiation, and I don't think anyone would disagree. But I'll let Dr. Buchholz comment on what type of radiation would be done in this case, and then maybe something to prevent skeletal related events. I'll let you comment on that, Dr. Radishar, and what additional systemic therapy you would do at this point. Dr. Buchholz, comments about radiation?
Yeah, there is emerging data coming out on a variety of different disease sites that management of oligometastases with ablative therapies of the metastases, whether it be surgical or with radiation, appears to offer some survival advantage. Specifically in breast cancer, there is an ongoing study conducted by the NRG that has yet to report the results, but hopefully they'll be coming out within the next year. So that was a randomized trial where oligometastases up to 5 metastatic disease sites were treated with a stereotactic radiation approach that uses more ablative dosages, not just palliative dosages. Or similar to this case, you could also entertain surgical resection of that disease. I don't know what would be exactly involved with resection of that and reconstruction, if that's an easier, challenging thing to do. But we'd probably involve an orthopedic oncologist to render opinion on that, compare it against the morbidities of radiation. It's certainly a reasonable thing to do. My preference would be to enroll the patient on a randomized trial if it was available in your institution, but if not, I think a lot of people are approaching these now with ablative stereotactic radiation approaches.
From the local standpoint, that's exactly what the patient got. She got radiation with symptom improvement quickly. She was seen by orthopedics who didn't feel that since her symptoms had improved and there was architecturally her leg was essentially stable at that point, they didn't want to do anything. The issue after a review of the pathology is the pathologists were pretty convinced it wasn't any technical issue with the bone. This was ER positive, HER2 negative. As such, we decided to optimize her endocrine therapy. We gave her an LHRH agonist, although she is still considering oophorectomy. We rendered her postmenopausal, started an aromatase inhibitor, along with the CD4/6 inhibitor, as well as a bone-modifying agent to treat and palliate metastatic disease.
Excellent. I think she got superb care, and one would expect no less.